So, hi everybody, you're all very welcome. Thank you so much for joining us this evening. This is the first of our menopause supports with Marks and Spencer, and we will be running these at Insta Lives at 7 p.m. over the next 4 Mondays. My name is Sinead McNamara. I'm the organizer of the forthcoming inaugural National Menopause Summit supported by Marks and Spencer. And this evening I'm joined by Dr. Caoimhe Hartley. And Caoimhe is the clinical lead at the Rotunda Menopause Clinic and also the founder and CEO of Menopause Health over in Dalkey. So we will be discussing Greystones. Did I get that wrong, Caoimhe? I'm so sorry.
No, you're right. We're based in Dalkey. I live in Greystones.
That's
I'm just spread out over all of Wicklow and South County Dublin, yeah.
I knew it was all over the other side of town.
That's right, yeah. No, we're based in Dalkey, yeah.
Yeah, okay, fantastic. So thanks a million for your time this evening. Really
Not at
appreciate
all.
it.
No, I'm looking forward to having a good chat. So
Excellent.
It's great. Yeah.
Excellent.
Hopefully get into some interesting discussion.
Exactly.
Some juicy topics. And
exactly.
See what we can come up with.
Exactly.
Yeah.
Let's bust some myths this evening, Caoimhe. I think that's
put those boxing gloves on, Sinead, and we'll get going. Yeah.
We'll be taking no guff this evening. We'll just be going for all the facts. So here's where I'd love to start anyway. I think we're all aware that HRT got such a bad rap over the years. So could you sort of lay out for us all exactly what the situation is with HRT from a safety perspective?
Yeah, you're right, because there's a long history looking at hormone therapy for women, and probably too long to go into in any sort of detail now. But I think what people tend to think of when they think of HRT and risk is breast cancer. That's what springs into most people's minds. And that's a kind of hangover from the Women's Health Initiative, which was the big study that was done back in the 90s. And they published their results in the early 2000s. Actually, it was the 20-year anniversary of them publishing their results last year.
Wow.
So it was 2002 that first paper came out. Mm. And essentially the kind of executive summary of it was that that HRT would give you breast cancer. Yeah. And, you know, hundreds of thousands and more of women were unceremoniously whipped off their HRT, like a rug just being, pulled from underneath them. And there then followed a few generations of women who also didn't really have that conversation, didn't have the option of discussing HRT at all. So I think that's kind of where we are now, is this, this indelible association in our head between HRT and breast cancer. But it's actually really complicated, because HRT is a term that we use for actually lots of different types of medications. It's not one single type of medication.
Yeah.
And so obviously all these different moving parts in HRT, they carry different risks and they carry different benefits. And when we say breast cancer is a catch-all term as well for actually lots of different types of diseases. There's not one breast cancer, there's loads of different types.
Yeah.
So I suppose when women come in to see me in the clinic, we try and condense all of that detailed information down into something that's actually manageable. And the easiest way of presenting that to someone is to say, look, what we know now is that if you're putting hard and cold numbers on it, I'm a numbers kind of gal. I like working with actual statistics.
Yes.
What we work off now is that we would see about 3 to 5 extra breast cancers for every 1,000 women who take HRT for 5 years over the age of 50. Now, I know there's a lot of caveats in that, but so basically average age of taking HRT is probably 50 to 55.
Yeah. So
for every 1,000 women who take 5 years of hormone therapy, and specifically combination HRT. So that's the type of HRT you take if you still have your womb.
Right.
Most women.
Yes.
We see 3 to 5 extra breast cancers diagnosed out of that group of 1,000.
Right.
Your baseline risk is probably about 23 per 1,000 women over 5 years at that age will be diagnosed with breast cancer, which is a lot.
Right. Yeah. Yeah, indeed, absolutely. So I suppose it's fair to say then that the risk is very much worth the reward, if I can put it like that.
Yeah, you're offsetting. So that's the bad news in a way. Is okay. Like, I think it's really important that women know that there is a small increased risk and that we're not trying to shirk that risk or shy away from it. It's there.
Yes.
Women who've had a hysterectomy and take estrogen on its own, we don't actually see a breast cancer risk for them. And that's really important to know as well.
Right, right.
But there's a flip side to that coin, which is the benefit, and we see a reduction in bone density loss. Osteoporosis is a hell of a lot more common than breast cancer would be. Osteoporosis is has a huge impact on on society and women's health in general.
Of course, yeah, absolutely.
And then we also see a reduction in cardiovascular risk. So
right.
Now, that's often overstated a little, just like the breast cancer risk can be overstated. The reduction in cardiovascular disease is actually pretty small, but it's not nothing. It's there.
Yes, yeah.
And I promise I'll stop talking in a second, but it's just
no,
so, like,
please.
so the
please,
other,
I'm sure everybody wants to hear this, so please.
I have a tendency to just go on and on when we're talking.
No, you're grand.
So there's, I think the take-home message when we looked at as if I sat down, was the only person looking at the Women's Health Initiative, when the researchers went back in 2012 and re-looked and revisited the Women's Health Initiative. What their take-home message was that if you look at a thing called all-cause mortality, so basically dying from any reason, throw it all into a big kind of melting pot and see what happens. There is a reduction in mortality for women who take any type of HRT.
Wow, well that's pretty significant, isn't it?
That's your take-home, I think.
Right.
Yeah.
Okay. Incredible. That's incredible. And I know this is the latest sort of thing that's trending in terms of HRT, and there's a lot of questions around this and a lot of vagaries around it, and according to some people it's amazing, and according to other people it doesn't really make much of a difference. What is the situation with testosterone?
Yeah, so your ovaries produce 3 hormones, estrogen and progesterone, when you're ovulating, and they're the 2 hormones, I suppose, at menopause that we see disappear. Because the little follicles that you make in order to make, to ovulate, to release an egg, they pump out estrogen. So when you get to menopause and you're not ovulating, and you're not making these follicles anymore, your estrogen falls. Same idea, if you're not ovulating, your progesterone's going to fall. But the 3rd hormone that your ovaries make is testosterone. And there's all controversy about testosterone at the moment. And the reason it's controversial is because we know so little about it. It's not something that has been studied for a long time in women.
Okay.
So we make testosterone from our ovaries, but also from your adrenal glands and from peripheral conversion. So other parts of your body will use building blocks for hormones and then turn it into testosterone.
Okay.
So Prof. Susan Davis is kind of the leading kind of global voice on testosterone, and she did a load of research in Australia. And she presented a thing in Lisbon last October, and they were talking about how if you look at the trend of what happens to your testosterone levels over your female life, you see a fall, like a reduction in testosterone has this kind of really slow, kind of gradual fall from your kind of mid-30s maybe onwards. And then inexplicably in your late 60s, early 70s, it starts to go back up again. And actually women in their 70s have on average, the same level of testosterone as premenopausal women.
Right. Okay. That's interesting. Yeah.
And we don't really know why, So I think it's interesting because I suppose we do lose testosterone slowly through our 30s and 40s and 50s even. But the relevance of that and the impact that has, it seems to be really individual.
Right.
Some women find that they get benefit from starting testosterone in their 50s. Their libido comes back. Anecdotally and somewhat controversially, maybe energy, maybe mood, who knows?
Right. Yes.
The cognitive function, but it seems to be very individual. So I can't sit in front of someone in the clinic and tell them, oh, you should go on testosterone. It's going to make all this, the cognitive function, the brain fog, it's going to make all of that better, because I can't back that up with science.
Right.
But there's some anecdote to suggest that. So it just seems it's all about counselling, and it's really individual.
Of course. And say, for example, one was a little bit late to the HRT game.
Okay,
right?
Define late now, Sinead.
Sorry?
Define late.
Well, I don't know. Say, for example, you were, you were had been, traditionally a little bit worried about HRT, and you decided, say, in your sort of mid to late 50s that you were going to now look into it and embrace it. Are there issues at that point, Caoimhe, or what's the situation in terms of getting on HRT that little bit later in your life, if you like, or in your 50s, should I say?
Yeah, so the British Menopause Society, they feel they did, I think, a meta-analysis where basically they look at all of the different studies that are out there, and they kind of come to a conclusion based on that. And their position really at the end of the day was that we think the vast majority of people will get more health benefit than they do risk if they start HRT under the age of 60 and within 10 years of their last period.
Right. Okay.
So I suppose the question is, well, what happens outside of that? So if I'm 60 and I rock into the clinic and say, look, I'm still getting hot flushes and night sweats, which is maybe 10 or 15% of women at least.
Right.
I have these menopausal symptoms and I'm outside of what we're defining as this window of time. What happens then?
Yeah.
So it's a bit complicated. I think cardiovascular, so your heart health is something that we pay a lot of attention to. We try to make sure that if women are older starting HRT, that we have their ducks in a row. We want to make sure their cholesterol is well controlled, their blood pressure is under control, that they're not smoking. So we try and modify those risk factors that are within our control as much as we can.
Right.
And I believe, although you'll find practitioners maybe vary a little, that to a point and within reason, especially if you're really confident these are menopausal symptoms that someone is getting, then, if you start low and slow, we use small amounts of estrogen gel. We use the really low dose patches. We go with what are considered to be the safer types of progestin to give them womb protection.
Right.
And see how you go.
Okay. And would you need a blood test, for example, Caoimhe, if you fell into that particular category, or do you just go, yeah, that's grand, here's the medication?
Take a number. Just take a number. Here's your prescription. No, no. We say so. Blood tests are interesting because they trip people up a lot, and I get asked about that all the time about bloods.
Yes. Yeah.
Really across the age spectrum. So I have women who are maybe 42, 43, still having regular periods, who come in saying, look, should I have blood tests done? I don't know where I am in the whole spectrum of menopause, And it's helpful to explain to them that through perimenopause, certainly, your FSH production, your estrogen production, all the things we measure are so variable and erratic. It's like trying to pin down a moving object. Like, there's just no point measuring them.
Right. Okay.
And equally, if we do measure them and they come back high, which is like in a menopausal range, that's not really telling me something I don't already know. And if they come back low, it doesn't mean your symptoms are not due to hormones. So
right. Okay.
But I would, for younger women, we would often check thyroid function. We'd make sure they're not anemic. We check an iron level. We might do a B12. Like, it would depend on what they're describing, but look at other potential causes. Women in their 50s who come in saying, my periods have stopped and I've got hot flushes and night sweats. Like, I could guess their blood work. I wouldn't even have to do it.
Yes,
but the same is true of your women, our example of this woman in her late 50s, early 60s.
Right.
Ruling mimickers of menopause can be helpful. Thyroid is the classic one. But other than that, like, your FSH is going to be raised until you get into your mid to late 60s. It's not adding any information. And we certainly don't base our HRT prescribing on blood tests.
Okay. And in the case of sort of a more non-complex menopause, Caoimhe, how long can a person stay on HRT?
You're coming at me with all the big controversial questions.
Well, I know everybody wants to know these things. It's not just me and all my friends. I think.
See, this is why they're interesting, is because we don't have black and white answers to this.
Yeah.
I mean, that's why I find it so interesting, because, like, I basically see the same thing all day long for the last 7 years.
Yes, you must be in Groundhog Day, Caoimhe, at this point.
But I'm not, because it's so nuanced and it's so individual. And that's what I really like about it, is that we live a lot in this grey area of not having firm guidelines and it not being black and white, and there not actually being a right or wrong answer. And that's really helpful, because it means a lot of the answer comes from discussion with the patient.
Right.
So shared decision making. So I'm not sitting there telling someone what they should or shouldn't do. I'm helping them wade through what we know for definite, what we don't know, and they make a decision based on that. And so it goes with kind of deciding, do I stop my HRT? Do I stay in it for life? So going back to our British Menopause Society's very helpful guidance, what they advise us to tell people is that they should stay on HRT for as long as their benefit outweighs the risk. Which would be so handy if there was some way of actually measuring that.
Okay.
Like, obviously,
if there was a magic equation like that you could apply to that, that would be convenient. All right. Yeah.
Yeah. I need some sort of magic abacus that I can sort of figure out. So instead, we look at a few factors. One is how symptomatic they are if they choose to stop their HRT. And sometimes the only way to know if you're still getting benefit is to come off it.
Yes. Yes. I can imagine.
Like, it's not.
Yeah.
So we look at that. We look at health. So I look at their bone health and to some degree cardiovascular health, but mostly bone. So I'll make sure they'll have an up-to-date DEXA, which is a bone density scan.
Right. Yeah.
And we use both of those bits of information. how bad do you feel when you stop your HRT? What benefit are you getting it for your symptoms? And where's your bone health at?
Right. Okay.
And if they stop HRT and feel like I'm absolutely perfect, I'm not getting that benefit anymore, that I don't need it in the way that I did before, and their DEXA is up to date and their bone health is normal, it is hard to justify continuing a prescription for that person.
Right.
But what we've changed, I suppose, if you go back when I started kind of learning about women's health a very long time, more than a decade ago, we would have been telling people, like, you get 5 years and then, like, you know, the bailiff's at the door, banging the door down, taking your HRT prescription off your hands and you were done.
Yeah.
Or you get to 60 and, like, I don't know, a big bell rings and again, your HRT is gone. But in
Right.
reality now, no arbitrary limits. So
right. Okay. So very much personal. Discuss it with your doctor.
Usually.
Decide how you'd like to move forward in that regard. Right. I'm going to sort of deal with a subject that I think a lot of women are, even, you know, dealing with. Lovely female doctors like yourself, Caoimhe, are very embarrassed to talk about in terms of the whole menopause piece, vaginal health. So what can you tell us about that, Caoimhe, and what best advice can you give us on that?
I think you should sit in the clinic with me for a day and never feel embarrassed about anything ever again. I think I talk about vaginas so much at this point. Like, but I think it's nice as a patient to know how little we feel embarrassed about it and how normal a conversation it is for me to have.
Yes, of course.
Because I think sometimes the patient is sitting there thinking, I've literally never discussed this with anybody. I just want the ground to swallow me up. So I think making the environment appropriate and making someone feel comfortable is really important. So yeah, vaginal health, I suppose, through menopause, really important your whole reproductive life, never mind just menopause. But I suppose the problem we run into through often in late perimenopause, you might still be having periods, and certainly through your early 50s on average, people start to notice that they get some vaginal or vaginal. I never know. One is American and one is European.
Some people are vaginal girls. I'm a vaginal girl.
You're okay. Let's remember that. Okay. Anyway, see, I think some people will notice that they start to get some vaginal dryness. Is the common one that kind of springs to mind.
Okay.
And really that's happening because your vaginal, the lower third of your vaginal canal, and the vulva, which is the external bit, anything that touches your underwear is vulva.
Right.
It's covered in estrogen receptors. And when that estrogen falls and drops and falls away, we see changes that happen to this tissue. They used to call it atrophy, and every time I say it, my skin just crawls.
I know that's just, it's so medieval. It's such an unpleasant word,
isn't it?
Atrophy, I know, like, really.
With or up from the inside.
Yeah.
So we've moved away, thankfully, from using that term. But yeah, essentially what's happening is with that loss of estrogen, we see shortening of the vaginal canal.
Okay.
So things tighten a little. So the vaginal canal gets a bit shorter. The vulval tissue kind of shrinks a little. Even your urethra, the tube that brings urine from your bladder to the outside, that shrinks a little. Even the bladder is covered. The detrusor muscle in the bladder covered in estrogen receptors. So it's all kind of the one, if you like.
Right.
The dryness comes from, obviously, lubrication is decreased. The pH falls, so it changes. With that, we see a change in the type of organisms that grow in this area, because we're all covered in bacteria. Like, it's normal to, you know, we have good bacteria that live in our skin, same in the vulval area. So that all changes because essentially you're going from sort of tropical climate, for want of a better way of describing it, to more sort of desert climate, right?
Right. Wow. Okay.
Yeah. So all of those changes contribute, and people may describe then feeling dry, feeling sore, feeling itchy, sex may be painful. You lose some sensation, so you lose some of your blood supply to the clitoris and vulval region.
Okay.
But actually it's a bit like falling asleep in your arm, like it can become numb.
Right.
And then you're at nothing having sex because you just can't feel anything at all. So that's doesn't do much for your libido, I have to say.
No.
And then other skin conditions can happen at the same time. So some people might develop, they're called dermatoses. So like irritability or inflammation in the vulva. There's an autoimmune condition called lichen sclerosis, which is a bit like eczema, like a skin condition. So these can all co-occur. So I'd have a lot of women who come in saying, I have thrush. Like, you don't have thrush.
Right. Okay.
Thrush,
okay.
You know,
very uncomfortable and very unpleasant for people, though.
Yeah, and we probably sort of belittle it in some ways because we're embarrassed and it's such an intimate part of us. But from talking to women, like I have women who say, you know, I can't play tennis anymore. I can't cycle. I don't have sex with my husband. I can't wear those trousers anymore. I can't do, you know, it's actually limiting some of what they can do.
Yes.
But for others, they're awake all night. It's itchy and uncomfortable. And it's,
dreadful.
And it's fixable, Sinead. That's the problem. It's
well, I mean, you know, so many people, as you would know better than anyone, Caoimhe, you know, years ago and maybe even these days are literally dying of embarrassment. I'm not saying that these women are dying, but people are, you know, so embarrassed, and even women so embarrassed, or some women are, to discuss these kind of issues. And why sort of sit at home and suffer when you can be sort of looked after very well by your GP or in your menopause clinic. So what exactly, Caoimhe, can you give us an idea, are the kind of delivery systems, if you like, for vaginal health specifically during menopause? Is it creams? Is it gels? What kind of products would you prescribe for that?
Yeah, I'd start with something over the counter.
Right. Okay.
Because I mean, why not? It's a good place to start with something that's non-pharmaceutical. So lubricants can be oil, water, or silicone based. They're used for sex. And for nothing.
Right.
So they're just literally slippy slidey, just used for sex. That's it.
Right.
And then you have vaginal moisturizers, which are different and have different components. They're often I can never say that. Hyaluronic.
Yeah, don't ask me either. Yeah.
Hyaluronic acid based. So their purpose is to make the kind of superficial layer, because anything you're applying that isn't medicated like that, it's only really affecting, a bit like with your skin on your face, it's only really sinking into the superficial epidermal layer. So what they will do is they'll make the vulval tissue a lot more supple, so there's a bit of give on it and a bit of stretch, but they also act as a nice barrier so that the now sort of thinner, more sensitive vulval tissue isn't going to get as irritated by what it's coming into contact to.
Okay.
I'm laughing because I'm doing all these hand gestures in the background and you can't see. I think I speak with my hands so much. Anyway, so yeah, there's this nice, I'm sit on my hand to stop myself waving around. So they create a really nice barrier. Dermatitis, the vulval dermatitis, we meet a huge amount of, and it goes hand in hand with vaginal atrophy because of the thinning, because of the sensitivity that happens. Anyway, so these vaginal moisturizers, really handy, will create a nice barrier, keep the skin really healthy. They're twice a week is usually how often you apply them, and they're over the counter. You don't need a prescription.
Right. Okay.
So let's say you're doing all of that, you stopped using perfume soaps, you're not, you know, doing anything else that might be irritating the area, but you're still uncomfortable. You'd have to be examined.
Right. Okay.
Like you have to be examined. So don't, you know, I have women who are symptomatic for, just eons of time, and they haven't, no one's looked.
Wow, God almighty, yeah.
Some of it is time constraints, I think, in general practice as well, because it does take time to have somebody undress and you leave the room and you come back in, and then, you know, but if you go in with a rash, you'd kind of expect someone to look at your rash. You would
indeed, absolutely, yeah.
Same idea. So we insist everyone has to be examined. So, and then if it's related to menopause, if we think it's low estrogen, we start with a localized estrogen product.
Okay.
They're not HRT. So they're systemic. They do not get into your system.
Okay. So they don't in any way, they don't in any way then clash with either HRT or any other current medication that you might be on.
Yep, exactly. They play really well with whatever you're on, usually.
Right, great.
They won't interact with anything that I can think of, if I'm honest.
Right.
With the exception of, women who've had breast cancer are a kind of separate group, and there are some medications there we're a bit more reluctant to prescribe localized estrogen with, but with that exception, in general, no, there's nothing that it will interact with. It's really safe. It isn't hormone therapy. It stays localized, like it stays in the vulval, vaginal, urethral, bladder tissue. It doesn't get into the rest of your system. And there's different ways of delivering vaginal estrogen. So there's pessaries, like tiny little tablets that come on a little applicator stick, usually. There's a form of like a little kind of rubbery bullet almost. And then there's a cream. And traditionally, we would prescribe them as something you'd use or apply every night for the first 2 weeks. Twice a week after that, then long term. Now, some people need a bit more, which is a bit of a pet peeve of mine, is that people think they can't take more than twice a week. And there's maybe a fear about prescribing them more than twice a week, but actually they are very safe to be used more than that, and they're lifelong.
Okay, right, interesting.
Yeah, so if you stop, you go back to square one.
So yeah, so you just continue as long as it's working for you, and hopefully it is, then you just can feel free to continue with the medication.
Yeah, and it's generally for life. And about a third of women maybe who are on hormone therapy will also need localized estrogen.
Right. Okay.
Yeah.
And here's another question for you as well, say for somebody who's going to talk to their GP or going to their local menopause clinic for the first time to discuss, their symptoms. Is there a particular, say, for example, document that you could download off the internet that would like literally list all of your symptoms, just so that when you're getting into the GP's office, you've kind of already done a little bit of homework and you can get into the nuts and bolts of the thing instead of kind of dancing around the houses and taking ages to explain what it is, what particular symptom is ailing you or what particular symptoms are ailing you. Is there such a resource that people can look up, download, fill in and head into their doctor with that?
Yeah, I'm sure there's loads probably available online. Though I like the Australian Menopause, the AMS, the Australian Menopause Society, have a really nice symptom checker. It's not too long, right. It's not too short, sort of Goldilocks-y. It's just, hits all the major points. And often people will kind of read through it and think, Jesus, I didn't even realize that symptom.
Yeah, because there are so many symptoms, aren't there, Caoimhe? That, I mean, I think back now, I'm 54 now, and I even think back sort of in my mid-40s and sort of retrospectively go, certain stuff was going on for me and I just thought, I didn't really know what it was. But it's only now that I'm more educated and have a broader knowledge of the amount of symptoms that one can sort of suffer from in menopause that I realize, actually, do you know what? That was perimenopause, but I just didn't realize it. It's incredible.
It's joining the dots. I think that's where education really comes in, and where I see a lot of the real benefit of the discussion that exists now, more than it did previously around perimenopause and menopause. One of the biggest benefits is that exact thing that I think it's helping women, like it's empowering, I think, to understand why I have these symptoms. And, that way I'm feeling kind of cyclically month on month. It's happening because of X, Y, and Z. And joining those dots and realizing, well, if it tips into a point where it's affecting my quality of life or my ability to enjoy things, well, I have options, and I know what my options are because I feel educated on it. So
yes, absolutely.
Yeah, so I think there's definitely empowerment in that, and I think that's a huge change even in my sort of career. If you looking back, when I would have started this a few years ago, I think a lot of women just couldn't join the dots because they didn't realize that there were these connections happening hormonally.
Yeah,
help with that.
Yeah, no, it is incredible. Let me see. I'm just looking down through all of my questions here, Caoimhe, and from my perspective, I have pretty much covered everything I think I wanted to ask you. But is there anything else that you feel we haven't discussed that's worth throwing a couple of minutes at before we finish up?
Where to start?
I know.
There's so much you could cover. I think there's a few areas that probably need to be a bit better about making sure, women are armed with that information. One is probably contraception, that women know when they need it and when they don't.
Right, okay.
The other is, and I have two others, sorry, this list will grow as I'm talking, but anyway, I think heavy bleeding is something else that I find frustrating from my perspective, because I have women who I talk to who have been putting up with horrendous periods for ages. Either because they figured there's nothing to do about it, or I don't have any options, there's nothing I can do, sure, this is just part of life, or they've been too busy. I'm too busy to come in and talk to someone. I've just too much crap going on, I'm too busy, and so they won't reach out for the help. But actually, we've loads of really good treatments for dealing with heavy bleeding. Nobody should have to be sitting at home with heavy periods.
Absolutely.
Or bringing a change of clothes to work. I had someone recently
constantly
a change of clothes, or someone else tell me they were on public transport and had to get off, or it's just brutal. Yeah,
it is brutal. And I think, going back to your point there, certainly back in the day when, it was all a big secret and a big taboo and all of that kind of business, I heard when I was way younger, I don't know, through the ether, probably pre the internet even being invented, you know, that like hideous periods when you're coming to the change is kind of normal. You know what I mean? It might happen to you. There you go. So it's not, you don't have to put up with that, is what you're saying. And you can go and see your doctor about that as well.
Yeah, the issue with, I totally agree with that. I think that's the problem. And it's the same with menopause, that we call it normal, because it is normal. Clearly it's normal. It is not a disease. And
Yes.
healthy periods, they're normal in that they're common.
Yes.
They're not a disease. Now, they can be due to some pathology, but like generally speaking, they're, you know, but it doesn't mean you have, like, if they're really affecting you,
Yeah.
why do we put up with stuff? Like, you can talk to someone and at least discuss your options and see what you can do. Got to prioritize quality of life. We're not here for all that long.
Exactly, and it's just so important, isn't it, Caoimhe, that people, not just women, prioritize their health. I mean, you know, it's such a cliche. Your health is your wealth. I mean, you look after yourself, because if you don't look after yourself, you certainly can't look after anybody else. And you know, so make sure that you're, you know, looking after yourself. How many times can I say that?
But what a positive way to kind of,
yeah,
you know,
sort of finish up. Exactly, because I think traditionally as well, women have a tendency, and I'm sure this will resonate with you, Caoimhe, and certainly resonate with a lot of the people that are here with us this evening, to put themselves way down the priority list in their lives. And you know, we have to take care of ourselves. It's so important. And from my perspective, and we will finish up now, because we've been on here now for just over half an hour. Like, you know, I'm certainly delighted to be part of that train that burst out of the station and burst out of the shadows and now is traveling at 500 miles an hour, moving the whole, you know, conversation around menopause into the public realm. And on my last little positive note is, it's as much as we have so much still to do, and to a degree we're sort of at the foothills of the conversation here, I'm certainly glad to be 54 years of age in 2023 as opposed to 1983. So onwards and upwards, I suppose, for all of us, Caoimhe, isn't it?
It's all positive, I think. Even, you know, things like today, the Menopause Summit, I think it's all moving that train forward. So yeah, it's great.
Yeah, that's fantastic. Super. Well, Caoimhe, thank you so much for your time. I think we'll leave it there. And as I say to everybody who's with us, we'll wrap up now, and look forward to seeing everybody then. Thanks a million, Caoimhe. See you soon.
Take care. Bye.
Okay. Bye. Bye.